For a case of menopausal symptoms or fatigue, hot flashes, decreased sex drive or vaginal dryness, or pain on sex or vaginal discharge, using our mnemonic old carts will note the onset or when did it start. For the location in a case of dyspareunia, we'd like to know where is the pain, in the lower pelvis area, in the vagina, outside the vagina. For the duration, for all cases, we'd like to know if symptoms are occurring constantly or daily, or if they're more intermittent. And if that's the case, we like to note the frequency. How many times per day or per week are we having hot flashes, pain on sex, or a vaginal discharge? To help characterize any bodily fluid, such as a vaginal discharge, we know by now to use our mnemonic A, B, and C to write down for our patient note the amount, if there's any blood, and the color. Aggravating and alleviating factors, radiation, treatments tried, and severity on a scale of 1 to 10. Or if there are none, we'll also be sure to state that in our patient note to show that we asked. For all cases, we should order a pelvic exam, breast exam, urine HCG, CBC, serum electrolytes, TSH, T4, and FSH-LH. In hypothyroidism, our supporting points will include menopausal symptoms, weight gain, cold intolerance, constipation, and fatigue. In hyperprolactinemia, and note again how we're keeping the differential broad and not using prolactinoma, our supporting points will include menopausal symptoms, galactorrhea, a headache, and visual field changes, and we'll add to our workup a prolactin and an MRI of the brain. Premature ovarian failure, perimenopause, and menopause are also sequelae of a similar disease process, namely ovarian failure. And if the patient's within a similar age range, we could generally include a few of these differentials in our note. In POF, our supporting points will include menopausal symptoms, amenorrhea, and an age less than 40 years old. In perimenopause, we'll see the menopausal symptoms, oligomenorrhea, and an age closer to 45 years old. And in menopause, we'll see menopausal symptoms, amenorrhea as typically defined for greater than 12 months, and an age closer or greater than 50 years old. And we could add also a DEXA scan. In vulvodynia, we'll see dyspareunia, and it's normally a diagnosis of exclusion. In vaginismus, we'll see dyspareunia and muscle contractions that prevent penetration, either on an exam or during sex. In vaginitis, we'll see dyspareunia, a vaginal discharge with pruritus, and a history of sexual contacts. And we could add to our workup a nucleic acid amplification test for gonorrhea and chlamydia, HIV antibodies and RPR for syphilis, a wet mount and KOH prep, a pH of the vaginal fluid, and cervical cultures. In cervicitis, we'll also see dyspareunia, a vaginal discharge with pruritus, and a history of sexual partners. And in pelvic inflammatory disease, we'll see dyspareunia with a vaginal discharge and pruritus, now lower pelvic pain, and a history of possible prior STDs. And finally, in endometriosis, we'll see dyspareunia with menorrhagia, dysmenorrhea, and dyschezia. And we'll add here an ultrasound of the pelvis, laparoscopy, and a PT and PTT as we do for any case that involves blood. Okay, we'll start our abdominal exam with a hand sanitizer, and we want to ask our SP if we have permission to examine you. We'll start with the hint exam. We'll look into his eyes, cranial nerve 3, 4, and 6. You'll instruct them to please follow your fingers with their eyes, keeping their head straight, and you can see that he's able to follow. We'll examine his thyroid, and so another good tip is to offer a glass of water. Would you like a glass of water? No. Okay, and now we could look to see if there's any visible lesions to the thyroid, and we don't see that, so we could ask him to swallow, and we could do one side at a time. Okay, now please swallow again. Okay, we didn't feel any palpable thyroid nodules. The thyroid, we're going to introduce this mnemonic that we'll see again with the MSK exam, which is MRCP, and manufacturer suggested retail price. And so this mnemonic will help guide you, along with the thyroid exam, the other components to look or to check for thyroid issues. So we'll start with the M, which is motor. So ask the patient to please make a muscle, and we'll test his motor strength. So he has 5 out of 5 flexion and 5 out of 5 extension. Okay, after the motor on the upper extremity, we'll do the same thing on the lower extremity. So we'll ask him to please kick out. Okay, good, and now please kick in. Okay, great. We're going to go ahead and move on to sensation, the S. There's no real need for sensation like a neuro exam for the thyroid, but we're used this opportunity to let it hold as a placeholder for cyanosis and delayed cap refill. So we'll go ahead and look at his fingernails, and you don't see any cyanosis. We could press on his fingers, and we don't see any delayed cap refill. Okay, next we're going to go to reflexes. So we're going to
start with the biceps, and we'll position our thumb on his biceps tendon and just instruct him to relax. Okay, and we'll see a 2+ reflex, and we'll do the same thing on his other side. Okay, good. And now we're going to go ahead and do the same thing on his lower extremity, his patella. So we'll instruct him to just relax, please. Okay, should give us a reflex. The SPs are trained to give us a good reflex. Okay, there you go. Okay, and now we're going to go on to pulses, and so we'll check the radial pulse, and you could do one at a time, or if you're a little more comfortable, you could do two, and you could comment that it's a 2+ pulse, regular rate and rhythm. We'll go ahead and do the same thing on the bottom, so we're going to check his posterior tibial pulse. So it will be behind the medial malleoli. We can go ahead and do one at a time, or if you're a little more comfortable, you could do two at a time. Just comment that it's 2+ regular rate and rhythm. And now once we're finished down there, it's always a good idea to hand sanitize again. So while he's still sitting up to the cardio exam to get that out of the way. So the best way to do this here is, again, to lower the gown slightly, to ask them to please sit and hold it like this. This will protect them and keep them covered up. We want to verbalize that we don't see any visible lesions anterior chest, no visible lesions to the posterior chest. And we'll go ahead and palpate and see if he has any chest tenderness. So please let me know. Okay, do the same thing on the back. Next thing we can do is auscultate for his heart sound, and so we'll use the mnemonic apartment M225A, and we'll listen first in his right intercostal for the aortic, and we'll go over to the left for the pulmonic, and then we'll go to listen to the tricuspid. And now for mitral, if this was a female, a good tip is to ask them to please lift up your upper breast. You could comment that we hear an audible S1, S2, regular rate and rhythm, no audible S3s, S4s, or murmurs, rubs, and gallops. Once we completed the cardio, we could transition nicely to the pulm exam while he's still sitting up. And so we could go ahead and percuss. We'll start above his clavicle, comparing left to right. And we're going to go ahead and do the same thing on the back, 3 spots. We could auscultate again. We'll start above the clavicle. We're going to use the bell first. Please take it, and the instructions you want to give is please take a deep breath when you feel my stethoscope. Please take a deep breath in and out. Okay, compare left to right. Do the same thing on the back now. Okay, now we could verbalize again that it was cleared auscultation, no audible wheezing. Once we concluded the cardio and pulm exam, we could cover him up again. Now we can instruct him. I'm going to now lie you down to do the abdominal exam. Is that all right? Okay, so we want to help them down. And you don't want to forget to extend the legs for the leg rest. Now you could rest your legs. For the abdominal exam, they'll have a gown here, and you want to move it up all the way to their pelvis, and then you want to ask permission to take it up. We want to do the same step again. We want to first verbalize that we see no visible lesions. First, ask if he has any pain anywhere. Okay. Now we could verbalize that we heard normal active bowel sounds, and then we'll go ahead and percuss in the 4 quadrants. Okay. And we want to ask them if they have any pain first. You want to avoid those areas. So do you have any pain anywhere? No. Okay, so we'll start in the lower quadrant here, and we'll do superficial first, just with one hand. We could make good eye contact with the SP to see if they have any pain or if they wince. Painful at all? Okay, now we'll go ahead and do deep, and for that we could just signal we're going to put one hand on top of the other. Any pain at all? Okay, so no pain. And then to conclude, we want to go ahead and check for hepatomegaly. So the best way to do this is to place your hand under the border of his liver. You want to instruct the patient to please breathe in. And then as he breathes out, you can breathe out now. You want to go all the way up into the lower rib cage, and as long as you don't feel the liver extending below, you can verbalize that there was no hepatomegaly, and you can do the same thing for the spleen. So again, please breathe in. And now please breathe out. Okay, and you can feel the lower left rib, and there was no spleen coming down. And now that concludes the abdominal exam, so you could help cover them again. And then sit them up. Could I help sit you up? Okay. And then you just want to ask them if they have any questions for you.
Yeah, that's